trị bipolar disorder. Và khi mà bệnh nhân bị ngộ độc lithium một cách mãn tính, thì chúng ta cần nên làm như thế nào? Thì có một bạn request rằng mình có thể làm một cái lecture về chỉ bên tiếng Anh thôi mà không có dịch sang tiếng Việt được không? Thì hôm nay thì mình muốn làm cái lecture đó. Các bạn nếu cảm thấy mình thích hợp với cái loại chia sẻ này của mình thì xin cho mình biết. Và nếu như thấy khó quá để mà follow thì các bạn cũng nên cho mình biết nhé. Mình cảm ơn rất là nhiều. Thì bắt đầu với lithium and acute, as well as acute on chronic lithium toxicity. The source of this lecture is from Up to Date and from Dr. Stoll's The Essential Psychopharmacology and Biological Psychiatry. So lithium is a drug, has been used under the class of Escalate CR, Lithobid slow-release tablets, Lithostrat tablets, lithium carbonate tablets, lithium citrate syrup. It's considered as a mood stabilizer. Most commonly used of lithium that I've seen in clinic is for manic depressive illnesses or bipolar. Sometimes it's used for maintenance treatment of this manic depressive patient with a history of mania. It's used in bipolar depression and is also used as an adjunctive or an add-on medication for major depressive disorder. Two of the lesser common usage of lithium is for vascular headache and for neutropenia. The word neutropenia means there's a decrease in white blood cell. So if a patient has high white blood cell, it is recommended, or lithium can be used to lower their white blood cell, because one of the effects of lithium is neutropenia. So how does lithium work? Lithium's mechanism of action has been very complex, and it has been unknown until the year of 2010, and a lot of research has been done, and there are many articles on the mechanism of lithium from Biological Psychiatry journal. In the past, it has been understood to alter sodium transport across the cell membrane in nerve and in muscle cells. It has also been understood to alter metabolism of neurotransmitters, later alters intracellular signal through the action on second messenger. It also plays a role in reduced protein kinase C activity and alters the genomic expression as well as neurotransmission. It also is understood to increase cytoprotective protein, activates signaling cascade utilized by endogenous growth factors, increases gray matter content, activating neurogenesis, enhancing trophic action that maintains synapses. Researchers are now beginning to understand how lithium really works. There are many ongoing research on lithium mechanism and how lithium can help to restore the brain volume deficits. Studies conducted on animals identify the neuroprotective as well as neurotrophic effect of this important medication. Discovery that the regional brain volume deficits in imaging studies of people with bipolar disorder. A generation of research studies identified there are alterations, predominantly the reductions in the size of the brain of people who has mood regulations. These studies also began to provide hints that some of the treatments for bipolar disorder would increase the volume of these brain regions. Bipolar patients who were not taking lithium that show the reduction in the cerebral and the hippocampal volumes compared to healthy comparison subjects. Bipolar patients taking lithium display significant increase of brain volume in the hippocampal and the amygdala volume compared with patients who are not treated with lithium and healthy comparison objects. Cerebral volume reduction has also significantly associated with illnesses during bipolar individual. illness duration of bipolar individuals. And here's our limbic system and how the lithium affects the limbic system. Limbic system, you can see it's a circular area that includes cingulate gyrus that we can see here in purple. It also includes the mammillary body and with the fimbriae in this area. Here's the amygdala and the parahippocampal gyrus in this area here. The limbic system is a donut shape that we see in the last structure, and it is a structure between the brainstem and the cerebral hemisphere. It is considered as a seat motion. It is also involved in motivated behavior like eating, drinking, and sexual behaviors. How does it really work? Well, the amygdala involves in rage and fear as well as emotional memories. The hippocampal area involves in memory as well. Then the hypothalamus is involved in eating, drinking, and sexual behaviors. It controls endocrines, the hormonal system through the pituitary gland. It is referred to as the pleasure center of the brain. Lithium toxicity, there are different types of poisoning. Acute is when a patient is not on therapy and they ingest too much lithium. It's either for suicidal purposes or to get attention of other people. Now, acute on chronic lithium toxicity is when a patient who is on therapy and ingests too much of this medication. Chronic lithium toxicity is when a patient on stable therapy suffers a decrease in renal function, therefore suffers an increase in lithium level. Pharmacokinetics on this medication, it is oral administration. The peak blood levels, it really depends on the types of medication that was given. 1 to 2 hours for immediate release products, 4 to 6 hours for sustained release, and then up to 12 hours may be necessary before the peak blood level to reach acute overdose. It is a small molecules with no protein or tissue binding. It freely distributed throughout the body water. There is an IV form of lithium that's available. However, it's not used as often as the oral form of this medication. Technically, a patient who has bipolar, usually it takes about 1 to 3 weeks in order for lithium to really work. Lithium excretes entirely by the kidney. It's freely filtered through the kidney, and there are over 60% of the medication is reabsorbed by the proximal tubules. Volume depletion or renal impairment can increase the reabsorption of this medication and results in increased level of this medication. So patient who has GI loss, who has acute decompensated heart failure, who has liver cirrhosis, who is taking diuretics, taking NSAIDs, taking an ACE inhibitor, can causes increased level of this medication in their bloodstream. Clinical presentation of a patient with lithium toxicity, usually it's important to take a very thorough history and do a thorough physical examination. Ask them about the formulation of the drug. Is it a PO form or IV form? The amount that was ingested, the timing that was ingested, when did he ingest it? What is the intent of taking this medication? Is it to treat their bipolar, to treat their major depressive disorder, or is it to kill themselves? Take into consideration of their hydration status, take into consideration of the medications that they're taking, like any diuretics, any ACE inhibitor, or any NSAIDs. Take into consideration of any co-ingestants that they're taking. Normally, clinical presentation of lithium toxicity is nausea, GI manifestation of nausea, vomiting, and diarrhea. Cardiac manifestation, prolonged QT, bradyarrhythmia, or a flattened T wave. Clinical presentation, neurological manifestation usually develop later in the stage of lithium toxicity because it requires time for this medication to be absorbed. They may present as sluggishness, ataxia, confusion, agitation, neuromuscular excitability, seizures, or encephalopathy. There are long-term sequelae that result from lithium toxicity, something called silent or syndrome of irreversible lithium effectuated neurotoxicity. They often presents with cerebellar dysfunction, extrapyramidal symptoms, any brainstem dysfunction, or dementia. They may also present with nystagmus, chorioarthroid movements, myopathy, or blindness. Take into consideration a differential diagnosis of lithium toxicity. These differential diagnoses may present patient may present symptoms that are similar to lithium toxicity, and they include serotonin syndrome, neuroleptic malignant syndrome, ethanol or benzoyl withdrawal, hypoglycemia, or CNS infection. Head trauma, CVA or cerebrovascular accident, seizures, intoxication of other medications, myxedema, or thyrotoxicosis. For laboratory initial labs, it's important to get a WBC. Lithium usually elevates WBC in absence of any kind of infection. Earlier, I said that lithium causes leukopenia, and I apologize. That is a false statement. Lithium causes an elevation of WBC or white blood cells, so therefore it is used to treat leukopenia. So it means that it used to treat a low level of WBC. Lithium can also cause electrolyte abnormality, acid-base disorder. Lithium usually do not cause acid-base disorder, but any kind of acetaminophen or salicylate or aspirin toxicity can cause this acid-base disorder. So getting electrolytes would be important to differentiate between lithium toxicity and acetaminophen or aspirin toxicity. It's important to get a BUN and creatinine level to check for any kind of impairment of the kidney. For a patient who has chronic lithium toxicity, they often has an increase in BUN and creatinine toxicity. Therefore, we can differentiate between an acute versus a chronic lithium toxicity. It's important to get some information about renal clearance too, because that helps to know about the function of the patient. Also, get a glucose level, get an EKG to look for any kind of QRS changes or any kind of QT prolongation. It's important to get a lithium concentration level as well. Now, with serum lithium concentration should be monitored every 2 to 4 hours. Early level confirmed toxicity, but that does not represent the peak level concentration, especially for sustained release tablet of lithium, because the level can increase hours later if it is an extended release tablet. After monitoring every 2 to 4 hours, if they are consistent trending downward the level of lithium, then you can change to getting the level every 6 hours to 12 hours. And if the patient is improving clinically, then we can monitor every 6 to 12 hours. There's little correlation between serum lithium concentration and the symptoms the patient present in acute toxicity. Treatment for lithium is important to cover ABG, airway, breathing, and circulation, and any kind of supportive care. Benzoyl is the first line for seizures. If patient is prone to seizure, get an IV fluid to maintain GFR or glomerular filtration rate to get the patient hydrate, replace fluid losses. Restoration of sodium and water balance is essential as well. So, and that we can get from normal saline. It's recommended from up to date to use normal saline 2 times the maintenance rate for the 2 to 3 liter, and then do continuous normal saline. GI decontamination by whole bowel irrigation with PEG solution for any kind of patient who ingests a large amount of lithium. It can also be used in awake asymptomatic patient who present within 2 to 3 hours after presentation with at least 10 sustained release tablets. Hemodialysis is an option if lithium is very readily dialyzable. Indication for hemodialysis is when the level is greater than 4, regardless of clinical status, or when the level is greater than 2.5 in patients with symptoms, renal insufficiency, or suffers from an illness that would be exacerbated by IV fluid. Lithium equilibrates slowly between the intracellular and extracellular. Therefore, after hemodialysis, there may be a rebound level of lithium, and that is considered to be not concerning. Next is deposition. Patients with symptoms of lithium toxicity are usually admitted regardless of serum concentration. Patients with severe symptoms should be monitored in the intensive care unit. Discharge the patient is appropriate once they are asymptomatic or their serum level concentration is less than 1.5. We can discharge them to psych units. It is recommended if the ingestion was intentional. So a patient want to kill themselves and ingest lithium, is important to discharge them to a psych unit. Outpatient setting, test before starting lithium. It's important to get a kidney function level, get a BUN level, creatinine level, thyroid function test, and an EKG in a patient who is more than 50 years old. Get a kidney function test every 1 or 2 times a year, and get a trough level, get a frequent trough level of lithium. For acute treatment, it's important that the trough level is between 1.0 to 1.5 milliequivalent per liter, and for chronic treatment, the normal level should be between 0.6 to 1.2 milliequivalent per liter. Determine the BMI of the patient. Lithium normally increases weight gain, so it's important to notice the weight status of the patient. Get a plasma glucose level as well, a cholesterol panel, and monitor the weight and BMI during the treatment. What are some of the side effects of lithium? Is ataxia, dysarthria, delirium, tremors, any kind of memory problems. It can lead to nephrogenic diabetes insipidus with symptoms of polyuria and polydipsia. It can cause diarrhea and nausea, and it can cause weight gain. One of the early symptoms with lithium toxicity is hand tremor. So that's something that you can notice on your patient to see if that's one of the first symptoms that occur with lithium toxicity. Next, lithium side effects can also damage the thyroid. Patient who may have an increased level of TSH but a low level of T4, this patient is considered to have euthyroid or hypothyroid goiter. They may present also with acne and some rash, leukocytosis, or an increase in white blood cell count. Side effects are typically dose related. There are life-threatening, dangerous side effects of lithium, and these include lithium toxicity, renal impairment, nephrogenic diabetes insipidus, any kind of arrhythmia, cardiovascular changes, sick-sinus syndrome, bradycardia or hypotension, T-wave flattening and T-wave inversion, any kind of rare seizure, rare tumor cerebri. What to do about the side effects of lithium? Well, first we should wait if it's an outpatient setting, wait, because usually you can lower the dose and reduce the dose, and usually the symptoms goes away. But if it's not, change to different lithium preparation. If there is toxicity side effects, that is symptomatic toxicity side effects, consider discontinue the medication immediately. If the patient has upset stomach, recommend them to take with food. If there is tremor, you can ask them to avoid any kind of caffeine source that includes caffeine and any kind of soft drink, tea, or give them a low dose beta blocker propranolol, 20 to 30 milligram every 2 to 3 times a day. That may reduce the tremor. With dosing and usage, usually in an acute treatment for lithium, we can use 1800 milligram per day divided into 3 to 4 times a day. For maintenance doses of bipolar, we can use 900 to 1200 milligram per day divided into 3 to 4 times a day. For an acute liquid form, we can use 10 milliliter 3 times a day. We can also use liquid maintenance dose of 5 milliliter 3 to 4 times a day. It's recommended to start the patient with 300 milligram every 2 to 3 times a day and adjust the dosage upward as indicated by plasma lithium level. When to stop lithium? Well, it is important to taper off this medication over 3 to 4 months because rapid discontinuation doesn't increase risk of medication relapse and possible suicidal ideation. Drug interaction, as we said earlier, NSAIDs, non-steroidal inflammatory medication can increase the plasma level. Diuretics can also increase plasma lithium level. An ACE inhibitor can also increase plasma lithium level. Metronidazole, because the effect of decrease in renal clearance, lithium can cause toxicity. Methodopa, carbamazepine, phenytoin interact with lithium and increase toxicity of this medication. Is it safe to use in a pregnant woman? No, it is not safe to use in a pregnant woman or any children who's under the age of 12. It is considered as a category D medication. There are evidence of the risks to the fetus, so discontinue before anticipating of pregnancy. We can substitute that with an atypical antipsychotic or an anticonvulsant if bipolar treatment is required during pregnancy. Recommend discontinue the medication during breastfeeding or bottle feeding. Because this medication can transfer from mom to infant through breast milk. So that is the end of lithium lecture. Mình cảm ơn các bạn rất là nhiều. Mong rằng cái lecture này có thể nó rất là nhanh nhưng mà có thể giúp mọi người hiểu được một chút về lithium. Ngộ độc lithium cấp tính và mãn tính. Các bạn nào có câu hỏi thì có thể email mình nhắc lại những cái điểm chính là lithium dùng để trị bipolar và rất là cẩn thận để monitor cái level, monitor cái function của thận và của thyroid, tức là thyroid, và cẩn thận là lithium cũng có thể làm cho lượng bạch huyết cầu tăng lên ở trong máu, cho nên khi mà bệnh nhân đang dùng lithium nhưng mà bạch huyết cầu tăng lên thì đó cũng là một điều rất là bình thường. Cũng cẩn thận, lithium toxicity có thể làm cho bệnh nhân bị bệnh tiểu đường, nephrogenic diabetes insipidus. Bệnh nhân sẽ uống nước rất là nhiều và chi tiểu rất là nhiều. Bệnh nhân cũng sẽ bị ngộ độc. Có những cái triệu chứng mà chúng ta thường gặp là bệnh nhân sẽ gặp run tay ha, bệnh nhân sẽ tinh thần sẽ bị mệt mỏi, bệnh nhân sẽ uống nước nhiều, đi tiểu nhiều, bệnh nhân sẽ cảm thấy buồn nôn, bị đau bụng, vân vân. Đó là những triệu chứng chính mà mình đã go over qua this lecture. Mong rằng có thể các bạn nào có thể có any comments or recommendation, có yêu thích cái cách mà mình chia sẻ bài hay không, hay là các bạn muốn mình chia sẻ qua tiếng Việt thì cũng có thể cho mình biết á. Thank you so much and I hope you all have a good day. Bye bye.